Ben has a patient that he's going to demonstrate the physical exam on you, and he will introduce the young man. He has a few slides that he'll show the patient history so that he doesn't have to actually ask the patient to answer the questions on the stage. This is a patient of Dr. Esch's.
Is my mic on?
Yeah, you're on good.
Okay.
And,
have a seat, make yourself comfortable. I've not met, this is Nathan Lewis. He's a patient of Dr. Esch's. I've not met him. I took the liberty of calling Nathan's dad to take some history so we could save Nathan the trouble of going through that. I can tell you that as I'm speaking, keep an eye on Nathan. I'm going to talk about a little bit of his history, but my exam has actually started already, just as Nathan came up to the front and as Nathan got up here and as he's sitting here. So we're going to go through some exam, but if I could get the two slides, I'll give you Nathan's brief history. Nathan is almost 16. He has in the past been a left-handed pitcher. His dad told me he began pitching at the age of 7, and he started throwing stuff at the age of 11. He was a very accomplished pitcher at a very young age. He pitched in the Little League Western Regionals when he was 12 years old, but during the Western Regionals, he felt a pop in the 4th inning. He was able to complete the game, 6 innings, but thereafter he was really unable to pitch effectively and has been unable to pitch effectively since that time. His team did go to the Little League World Series. He tried to pitch, wasn't as effective as he would have liked to have been. Lasted 4 innings and saw Dr. Esch. X-rays showed approximal humeral physis widening. And so Jim suggested to his dad that he take some time off, and his dad was great about it. And actually, he took 8 months off and then gradually returned to throwing. Could I have the next slide? In the fall of 2006, he was throwing with 3 or 4 days rest. His dad tells me pitch counts were observed and he wasn't really throwing that much. Developed a little shoulder pain, did some stretching. He's at the point now where he's playing the outfield. He cannot throw without pain on the top and in the back of his shoulder during the cocking phase of throwing as you're bringing the ball back. The pain is a dull ache, nothing sharp, nothing radiating down his arm. He has no pain with acceleration or follow-through phases. He, about 2 weeks ago, I believe, underwent an MR arthrogram, which Jim tells me is completely normal. I asked his dad if he participates in other sports. He does not. Asked if he has had any other injuries. He has not. And I said, did he ever sprain his ankle? And his dad said, yes, he has, and that his ankle still bothers him. So that's the history. Is there anything anybody else wants to know from a historical perspective? You mean catching, popping? Yeah. No. Okay? So we'll do the exam. Now, I would have done that interview with Nathan, but if you look at Nathan just as he's sitting, okay, his head and neck are forward, his shoulders are drooped, he's got a thoracic kyphosis, and he's got his abdomen sucked in. So he's the postural dysfunction that we talk about. Okay, so go ahead and take off your shirt if you don't mind. And Giovanni, please, anything that I'm not seeing that you see? Okay, so let me get you standing up first. And I'm going to try to look in the monitor and do this, and you just face out that way. And I'm going to just step off here for a minute so I can take a look at you. Okay, what I'm seeing with just that little step away is his right shoulder, just look straight ahead if you don't mind. Right shoulder is a little bit low, not terribly, but a little bit low. Clavicle is a little bit level. Nipple line is pretty even. His arms are in front of his body. And let me turn you this way. Again, it's easier to see that his arms are in front of his body here. A little bit of an anterior pelvic tilt. And now if you would turn and face the other way, please. And on this view, actually from this view, his right shoulder looks a little bit elevated. Here's the tip of his right scapula. Here's the tip of his left. So this one seems to be a little bit lower, and this one seems to be a little bit farther out. Okay? So put your hands on your hips for me, all the way up on, put your hands right up there. This is what I use as a little cheat on my exam, because if I'm looking from the back, here's the inferior pole. This is, Ben Kibler looks at the lateral scapular slide. He looks at 3 positions: arms at the side, hands on the hips, and arms out to the side in internal rotation, and measures from the spinous process of T7 to the inferior aspect of the scapula. But if you look at Nathan, here's the inferior pole of his left scapula. Inferior pole of his right scapula is way out here. So his scapula is, to me, laterally translated. Okay? Now bring your arms down at the side. And his hands are still forward. Here's the tip of his elbow here, which we'd like his antecubital crease to face that way. And so he's internally rotated on both sides. And if I put his scapula into position right about there, his hands still don't come down to his side. It's still coming somewhat forward, which to me is an indication that he's got some tightness of his cuff superiorly, a little bit posteriorly, or his deltoid, because his arm is coming out a little bit. Let's try rotating you just a little bit. Does that? Okay. So if I bring his scapulae where they belong, his arm actually comes out. And that was the problem we had in that thrower with the drooping shoulder. Okay? So in order for him to get his arm to his side, his scapula has to rotate in this direction. Okay? So now face that way again. And I'm going to step off the stage because I'm going to ask you to do a couple of things. I'm going to ask you to bring your arms out to the side, up and overhead 5 times. Because statistically in the lab, Ben Kibler has shown that 5 reps will fatigue the periscapular muscles a bit. So just bring your arms up and overhead 5 times, like you're flying. Okay, and let me have you step back just a little bit so your hands don't hit the table. Perfect. And by the way, while I'm down here, let me just look at, he has a little bit of a pelvic tilt to the left. His right pelvis is a little bit higher than the left. And while I have you in that position, I'm going to have you do this for me. Stand on your left leg, bring your right knee up, and do a squat for me. Little problem with balance there. Now, if you're not sure of that, bring your right leg out to the side. Now you're going to ask him to recruit a little bit more, and now go ahead and squat down. And again, he's going to internal rotation, which is a sign of hip external rotation weakness. But let's see what he's got on the right side. Stand on the right, bring your left knee up, and do it slower, a little bit more control. Really not too bad. Do it again. Okay, a little bit of corkscrewing now. Do it one more time, a little bit more slowly. Okay, lumbopelvic really not too bad on him. Okay, now face forward the way you were, please. I'm sorry. And now bring your arms very slowly out to the side, up and overhead. Keep your elbows straight. Is that hurting to come up? Okay. And now bring them down slowly. Okay. A little bit at the end. His scapula kicks out. But what I find is that more frequently I can identify it on eccentric function, meaning lowering the arm, coming down from forward flexion more so than abduction. So bring the arms forward, up and overhead, all the way up. And now bring them down slowly. There he is. Okay, so what's happening as he comes down, his scapula is moving up and internally rotating so that he's got medial scapular border winging. So go ahead, forward again, please, Nathan. Right here, here's the inframedial corner of his scapula on the left. Here it is on the right. Okay, so he's out farther, which to me is a loss of an external rotation control of the scapula. So bring the arms up and overhead. No pain when you do that? Okay, so in him, I'm sorry?
A little bit, actually.
Okay, so I was going to say we don't have to do a scapular assistance test.